Here, is Julie around?
Yeah, I'm here.
You happy we start, Julie?
Yes, I think David Bucker was having problems joining. I did send him wanted the meeting link, but it's just, but I don't think he's joined just yet.
Minu's not online, is she?
Minu's here.
Yeah. No, not Minu, I meant Mamuda. Just going to mute a few people because it seems to have some noise on there. I think we'll get started, actually. Okay, Julie?
Yep.
Okay, right, in which case, welcome everyone. No public questions, Julie?
No public questions.
Okay. Apologies.
Aileen Feeney.
Oh, yeah.
Apologies for lateness. She'll be joining us a bit later.
Okay, that's fine. Thank you. Declarations of any other business? Declarations of interests in terms of the register or agenda items? Minutes of the meeting on the 10th of November, that's 5.1. Any corrections, please? No. Action log on matters arising. I couldn't see anything that was outstanding. Anyone got any comments? No. Okay. There we are. This is for Caroline's benefit. We're speedily on to item 6, the integrated care pathway patient story. So Caroline Edwards, welcome. And I think the floor is yours. Can I just ask roughly how long you think you would need?
Oh, about 10 minutes. That's maybe fine. Less.
Well, so I don't cut it too short, but just thanks so much.
Okay, good morning, everybody. I'm Caroline Edwards. I'm seconded to the Trust. I'm the Integrated Pathways Manager for East Berkshire. So I'm going to give you a patient story and feel free to ask any questions at the end. So the background is an 84-year-old male lived with his wife in a one-bedroom cluttered bungalow with no package of care. His previous medical history, he had heart failure, CKD type 3, stage 3 with atrial fibrillation, non-insulin dependent diabetic with septic arthritis, agitated depression and bipolar affective disorder, and was on the mental health register. Prior to the start of the pandemic, the patient had been walking independently outside and was able to go swimming and attend social activities. But his mobility had deteriorated over the summer and he became less mobile, which impacted on his mental health. The patient had developed a grade 2 pressure ulcer on his sacrum due to sitting in his chair for weeks and was not able to get dressed and had been squatting over a bucket to use the toilet. He was under the district nurses for blood tests and for dressings for leaking edematous legs and under the heart function team to monitor his heart failure. In October, he reported to the DN team that he had become very low in mood, feeling depressed and didn't feel there was anything that could be done for him. Openly frustrated with his mood, and the district nurse referred him to the community matrons on October the 5th when he was referred and discussed by the team. But he was initially reticent, saying, well, what can they do? There's no point as they can't make my legs work. The patient was taken to the LAP, which is the local access point, a huddle between mental health, social services and the matrons. The mental health team reviewed his notes as he was previously diagnosed with bipolar disorder in 2005 and discharged from the team in 2016 as he was considered to be in a stable mental state. The LAP referred him to his GP for a medication review as there were concerns he was not compliant with his medication. The GP review signposted him back to the mental health services if necessary. He was also referred to podiatry for overgrown toenails, and a joint visit with 2 matrons was arranged to discuss the decisions with the patient. During this joint visit, his mood was assessed and he scored 10 out of 15 in the geriatric depression scale. He was referred to the community mental health team. The patient and his wife found his medication regime very confusing, so a blister pack was arranged. The patient and his wife appeared to be unaware that he was a type 2 diabetic, and the matrons arranged for his bloods to be checked, his HbA1c. One of the matrons had previously worked with the intensive rehabilitation team in East Berkshire and referred him to the team to try and improve his mobility, as this was something the patient repeatedly reported to be his goal. He was discussed the following day and a referral was made to adult social care due to his living conditions, and an OT assessment was requested. The CM continued to visit to monitor his low blood pressure and support the patient's wife with dealing with the new dosset boxes that they put in place. The intensive care rehabilitation visited the patient on the 12th of October, and he was initially assessed by the lead physiotherapist. The patient had been sleeping in his chair for 2 months, and on examination, he did not have full extension of his knees and was unable to stand, transfer or mobilise. The ICR continued to work with him for 2 weeks, and the patient told the therapy assistant he was a lost cause, but remained engaged and often tried to do more than he was physically able to. The therapy assistants also worked with him to improve his outlook and keep him positive about his goals. The senior physiotherapist revisited the patient after 1 week and found that extension on his left knee had improved by 5 degrees and was almost able to fully extend his right knee, but he lacked the last 5 degrees on extension. The physiotherapist arranged for an in-reach frailty practitioner, the OT, to visit with to explore the possibility of some equipment and like frames to assist with him standing from the chair and mobilising around the house. The OT visited and found the patient environment quite cluttered, offering him a hospital bed and a commode to help with toileting. The patient declined as he didn't feel there was enough room and didn't see the point, but he agreed to a frame. ICR continued to visit, and the matron visited on the 26th of October. The patient was still experiencing discomfort and was possibly developing an infection in the pressure areas which were not healing. He was spending a lot of time sat in the chair and sleeping. He was unable to fully stretch out. The patient they felt the patient would benefit from inpatient rehabilitation on the community wards, as he'd made a lot of improvement with his exercises, but still sleeping in the chair was preventing him from progressing any further. She discussed this with the GP, who advised she couldn't arrange the admission to the wards and was sent him to the acute hospital. The matron explained that this was not necessary and she would arrange the admission to the community ward and organise this with the Jubilee ward doctor at Upton Hospital. The matron discussed the referral with the patient and his wife, and he initially declined, telling her he was scared to go in. The matron asked another matron to accompany her on a joint visit the following day, and they explained the benefits of admission to the patient and his wife. After a lengthy discussion, the patient consented, and this was arranged for the following day to give him time to prepare. On arrival to the ward, his initial assessment with the physiotherapist, he discussed the goal of being able to walk independently. The patient required assistance of 2 with all transfers, and the OT arranged an access visit to with the possibility of a hospital bed and equipment being installed in the house. They explored the option of an interim placement while the home environment was prepared for discharge. He initially scored 4 out of 20 on the elderly mobility scale. The wife was very much involved in discussions with both patient and the wife, being given time to consider the options. His knee pain was managed with fentanyl patches, and his leg edema improved significantly on the wards. He was mostly engaged and compliant with the therapy he received, and his mobility improved dramatically to being able to transfer without assistance and mobilise with a frame. Social services assisted the wife in decluttering the house, and the patient was discharged home on the 10th of November with referrals from the DNs to continue monitoring his leg and pressure ulcers. The patient was again referred to ICR on discharge from Jubilee ward to continue the physiotherapy at home. The senior physiotherapist visited on the 11th of November and noted a dramatic improvement in the patient's mobility, from being able to stand up, from not being able to stand up from the chair to being now able to walk independently. The patient told the physiotherapist that he was delighted with his progress and was grateful to all the staff who'd helped him regain his mobility and the treatment he'd received on Jubilee ward, saying it felt like a hotel. The district nurses visited him the same day and noted that his leg ulcers, his pressure ulcers and his leg damage had completely healed. He's since been reviewed by the heart function team, who are going to discharge him in the new year as his heart function remains stable. He's been discharged from the GP cluster, and he's been reviewed last week by the mental health team, and has been stated that he remains in remission from his mental health. This is an excellent example of integration and admission avoidance, with a really positive outcome from the patient, who is now independently walking with a walking stick.
Very good, Caroline. Thank you very much. I just are there any sort of, clearly a lot of people involved as patients got a lot of comorbidities. What are the sort of lessons that come out of this in terms of the wider use of these integrated systems? What sort of lessons should we be, taking from it?
I mean, I think something that I noted on this was that I think this gentleman was left for quite a long time before we, a couple of months when he'd lost his mobility. So potentially we missed him at the beginning with the welfare checks. That he was gradually deteriorating. I mean, I think the fact that the matron had worked previously with the rehabilitation team is what led for his rehabilitation to start. So maybe if he hadn't been seen by that matron, would he have been referred? I don't know. So maybe there's a lesson to be learned about education within the services of what we offer, perhaps.
Okay, Naomi, you've got a question.
Yeah, thank you, Caroline. Really informative presentation. It struck me that the role of the wife, very important there, you know, and clearly she was struggling as well. And it, you know, I mean, perhaps logic would dictate that for his condition, his recovered condition, to be sustainable, she plays an enormous role in ensuring that, or participating in that. So any insights with respect to support for her?
I know that the matrons were very supportive of her with supporting the patient with his medication. She was heavily involved by the ward, involved in case conferences about his discharge and the plans, and with the OTs having the house readjusted for all his equipment. I mean, I think you're right. I think there probably are things that could be learnt there, particularly when he was referred to the lap, for the wife potentially to have some carer support, because he was particularly low mood, and I know that was affecting her mental health as well.
Thank you. Any other questions? I've just got one, Caroline, which is about who is responsible for a patient like this with multiple issues, to making sure that things don't get forgotten or down, you know, fall through the cracks. Or is it logged somewhere? Does someone say, of all these different specialisms, that someone takes on the responsibility of making sure that all the others are coordinated, or is it done sort of specialism by specialism?
I mean, I think that is part of the matron's role. The matron's role is managing these complex patients, and that's he was referred to the matrons by the DNs. And I think once that happened, things did start to happen quite quickly. And the fact that he was involved in the cluster meetings with the GP, where other specialisms come in, social prescribers, and obviously the GP. So I think once the matron got involved, I think that's when things started to take shape.
But I do find, even myself, that when you're told things, you know, from your GP or whatever, it's quite difficult to retain them. And if you're, you know, not in the best of health and you've got multiple conditions, that communication issue, I think, is quite an important one. I would surmise. So, but anyway, anything else? Debbie, did you want to say anything?
I just wanted to say thank you to Caroline, really, and we just wanted to give a bit of a case study really about someone who actually was really not managing very well at all in the community, and actually had that pathway continued, may not have been able to stay at home, but actually because of the interventions is now actually mobile with a stick. And despite the fact he was very pessimistic that would ever happen, actually a really good result from all that interaction. So it does show the value of the integrated hub and the working and pulling all the professionals together in order to really support somebody.
And he is delighted. He's very, very happy man.
Can I ask a question, Martin?
Please.
Hi, Caroline, Julian.
Hello.
Just obviously that's a brilliant example. The board have sort of heard a little bit about the integrated hubs, but I suspect if we were to ask them all exactly what goes on there, they probably wouldn't know too much, I guess, really, other than that there's probably a sharing of different disciplines and stuff. How are those integrated hubs sort of working generally? Obviously, this was a fantastic example. But how are they coming together and how are they functioning at the moment, would you say?
So the labs in East Berkshire have been up and running. I think they started full time just before I started, sort of in March, and they're working really well. So it's a daily huddle. We have a matron in there full time, and it's mental health, social care, and the matrons. And they are identifying these patients with an urgent need and are managing admission avoidance really very well. And it's actually seeing a decline in some areas of patients going to cluster, the sort of long-term discussions, and some of these patients are getting picked up quite quickly. But this is the kind of patient that they're exactly designed for, those ones that are at risk of admission within 48 hours. And these services come together daily to have those discussions that sometimes could take weeks to sort these issues out. And it's really improving that integrated working between health, mental health, and physical health, mental health, and social care.
Very good. Well, Caroline, thank you very much indeed. Very interesting, and let's hope we can spread this system working even more. Thank you very much indeed.
Enjoy the rest of your day.
Thank you.
Take care. Bye.
Thank you, Debbie.
Thanks.
I think we got to move on to freedom to speak up, and I think Mike Rosati is here.
Yes, good morning, everyone. My 6 monthly Freedom Speak Up report covers July through to December, but the data that I've shown in the report is for Q1 and Q2 of this financial year. So I'll take it as read that everyone understands the principle around freedom to speak up, and just highlight some of the key activities and data that are relevant for this period. Despite COVID, the communication plan has continued pretty much as planned. Hasn't really been affected at all. So we've had various activities throughout this period. Obviously, it's been difficult to raise the profile of freedom to speak up through face-to-face interactions, team meetings, etc. But a lot of it has been done virtually and has worked very well. So October was Freedom to Speak Up month, and there was a whole range of activities across that month. The theme was the alphabet, the ABC of freedom of speaking up, from A, action, through to Z for zero tolerance. There was an interview with a key researcher and author around listening up as part of the Connecting Across Boundaries event. And I've been present at all inductions and have increased my presence throughout the EDI community, becoming a member of the diversity steering group and working a lot with the staff networks. So the communications plan hasn't really been affected by COVID. And in terms of the number of cases, I've had very few COVID related cases. Back in sort of June, July time, there were a few around PPE issues or a bit of confusion perhaps over annual leave and how much of that could be carried forward to the next year. I haven't included those as official cases because it was basically just me giving some advice, people looking for another source of advice on an ever-changing landscape when advice from Debbie and others was changing on a daily basis. But in terms of the number of cases, there's been a significant rise. So you'll see that for the first 2 quarters of the year, I've had 28 cases, and the whole of last financial year, there were 31. I put this down to the effectiveness of the communications plan, really. I don't think there's more happening. It's people understanding more about freedom to speak up and feeling enabled to do so. So I see that essentially as a positive. In terms of themes, originally freedom to speak up was around patient safety issues. I essentially don't get any. Some of the staffing issues might affect patient safety to a small degree, but during this period, I've had no specific patient safety issues. Again, that is taken as a positive in that there are normal routes for raising patient safety issues, and everyone seems confident that they are working as they should, and the organisation isn't missing out on any information. So most of it, or pretty much all of it really, is around the staff experience, and about 3/4 of that is unfortunately bullying and harassment. So the staff experience type issues is about 7 or 8 categories, from staff safety, behavioural issues, issues around processes or the system, the infrastructure and environmental issues, or bullying and harassment, and most of it has an element of that. You'll see that it's mostly workers that come to me rather than managers, and in terms of professional groups, mostly it's nursing staff. In terms of staff with protected characteristics, round about 60% of the concerns that I've received come from staff with a BAME background, and half of those are around BAME issues. I've not been approached, not knowingly, been approached by anyone from any other of the staff networks with any concerns around their own protected characteristics. Looking at Appendix 1, which is the feedback I've received, the BAME staff that have come to me are predominantly of Asian background, and whether there is something to be read into that, I'm not too sure. The sample of returns I've had, so out of those 28 cases, I've had 9 feedback forms returned. Some people have left the organisation. Some people just choose not to give feedback. In terms of the National Guardian's Office, I suppose the most significant thing they've done or are doing at the moment is around training. So there's some e-learning packages coming out. The first one is out, and that's a generic core training for everyone around speaking up, encouraging staff to speak up. And then the other 2 will be coming out in the new year at some stage, and that's more around listening up and following up. So for senior managers to essentially show that they have listened to the concerns raised, and that there is perhaps a shift in culture towards listening to the concerns and feeding back to those individuals. I've included all the free text quotes there from the feedback forms that I've received from staff, and you will see that in general they seem to be very happy with the process of freedom to speak up, and how that works for them, and the support that it gives them and the voice that it gives them. But there are still some things to be learnt and some actions, perhaps how the organisation responds to those concerns in the way that it's communicated, so that everyone may be listening and there may be change, but how is that really being fed back enough to the members of staff? So in the Appendix A, you have a full breakdown there by age, ethnicity, etc., of those that have chosen to respond to me. As I said, it's quite a small section, a sample, but hopefully over time we'll be able to build that up and see if there are any specific patterns there or things to be learned. So that essentially is my 6-monthly report. I'm very happy to take any questions.
Right, thank you very much indeed. I've got something just to kick off.
Sure.
It's about follow-up, because I get the impression from what you said and reading the report that the process is now becoming familiar and staff have confidence in the process. It's more about what do we follow up with the people who raise the issue, what the consequential solution or decision is about it. I couldn't see it really in the report. So to know whether people have been felt free to raise the issue, it's been logged, but it's not quite clear to me that we've got visibility of and so what.
Yeah, so there's continual feedback throughout the whole process to the individual. But in terms of resolution, I think it's around expectations. So people's expectations might not match reality. So they take a long time plucking up the courage, if that's the right word, to come and talk to me. And as soon as they do, they want things to be dealt with very quickly, and they know in their mind how they would like it to be resolved, and it doesn't always match that. So it is difficult in certain cases to give full resolution because of that. But there is continual feedback. Whether we could do more, yes, we probably could.
Alex.
Yeah, I was just going to say, it's fantastic that Mike is working very closely now with the Diversity Steering Group and with the People Directorate. And I think what we need to do more broadly is take the learning that Mike has and colleagues that are speaking up to Mike in terms of how we pick up some of these issues earlier so they become less interacted with people. And one route to doing that, we're very explicitly covering bullying, harassment and discrimination in our people strategy and EDI strategies, but we're starting to think about how we work with the networks to support mediation and some training into colleagues so that they can pick up these issues with people experiencing bullying, harassment or perspectives of bullying and harassment early. And we're also reviewing our formal HR outcomes and process in terms of the BAME impact from that also. So really how we get to formal processes and picking things up early. So Mike's experience and experience of individuals through this is really valuable, as well as the feedback loop to individuals.
Thank you very much, Alex. Chris.
Thanks, Mike. Very, very clear paper, and I share your, the likelihood that the increase in the number of references to you is as a result of good communication. We always seem to see that, whether it be needle sticks or anything else. The more we communicate it, the more we the more we hear back. One thing that did quite surprise me in what you said, because I hadn't quite picked it up from the charts and the numbers, was of the, if you like, disproportionately high BAME referrals, and within that Asian community referrals. I just wondered what your sort of plan is to, I don't know, sort of act upon that. Are you, what's the plan of attack? Are we going to try and sort of understand that a little better? How are you going to respond to your impression?
Yeah, so as I said, it's a very small sample, and it's only representative of a small number of people that have responded to me, and I'm working very closely with, as Alex said, the staff networks and diversity steering group, and will feed back to them and HR on my findings so that we can do a deeper dive into it and see, is it just because to be honest, I don't know. I don't think it's a big enough sample to give a proper answer, but it's certainly something that I've been focusing on and communicating to the networks and HR.
Okay. Thank you very much. David Buckle.
Thank you for the report. I'm a bit bemused. We have to provide quarterly submissions to the National Guardian's Office, and yet we can't compare our numbers with theirs. I can imagine it's difficult to compare content, but are we not able to see whether our submissions are, broadly speaking, similar to others?
In fact, we're doing better, if that's the right word, than others. because of COVID, they haven't released national figures for Q1 and Q2. In pre-COVID, they would have done so, and I would have been able to provide a comparison. What we have looked at is the comparison between
other than just moving them onto another team.
Yeah, sounds very wise too. Mike, I think time is against us, but can I just echo the comments earlier to thank you for all you're doing. It's clearly you are seen as an approachable person and trusted person, so thank you for that. I think it's great that staff clearly feel able to use the process, and hopefully that'll develop further. And that includes BAME staff and difficult issues like bullying and harassment. I'm pleased that patient safety, that staff seem to feel there's obviously a process outside the Freedom to Speak Up, which is working. That's good news. We've talked about the managers, and I just think it'd be useful as things develop to think about the follow-up, to learn the lessons from, are the common factors and things, and I guess that'll build as we go forwards.
That's all work in progress, yeah.
So Mike, thanks ever so much indeed. You've set us a task to agree some text at the bottom of page 27, recommendations. It's pretty straightforward, I think. I'm sure we're all content, unless you wanted to explain something that maybe isn't always obvious.
No, I think it's pretty straightforward, and thank you for your continued support. I know that I'm lucky in that some of my colleagues in other organisations don't have the high level support that I enjoy. So thank you very much for that.
Thank you very much, Mike. We'll let you go then.
Thanks very much, and a Merry Christmas.
And you. Item 6.2, Quality Assurance Committee. David, just I think take it as read, but things you want to raise, and there's a couple I can see.
Thank you. Well, you've got 3 papers, including the summary, and I think the summary is a very accurate record. The meetings are running smoothly, and I think they give us a high level of assurance. So actually, I don't have any matters to raise in a form of concern. It's the opposite. We did look, and you have got the papers here, we did look at learning from deaths, and there were no lapses of care. And of course, we've got the Guardian of Safe Working, which gave us assurance that our junior doctors are not being asked to work in the ways that the NHS might have asked them to work 20 years ago. So that's very assuring. Just to mention that Debbie did give us a good, there was a good item on our usual SIs, and we are looking at the Royal College of Psychiatrists accreditation system, which is a voluntary system, and that gives me another level of reassurance that our processes are good. I suppose. Oh, and clinical audit, there is quite a lot of detail there about clinical audit, none of which I want to raise today at the board, but just to say that we do look in detail on areas of clinical audit that I think need consideration. So finally, maybe I take this opportunity just to ask Debbie to give us an update on where we've got to with the flu vaccine uptake, because it had been a bit on the low side. And I know the television had nothing else other than the first COVID vaccine this morning. So it might be topical to ask Debbie about the flu vaccine rate. Over to you.
Yeah, so good news, I think. So we have achieved, as of last night, 78% of our clinical staff and 80% of our total organisation, which is a greater uptake than we've ever received, and is very comparable with other organisations, and better than many. So we are still continuing. Originally, we were told we needed to complete the vaccination programme by the end of November for COVID, but because the vast majority of organisations in the country haven't achieved the aspiration of 90%, we are still continuing, although most staff that are going to have had it now, I think. But it's good news to hit the 80%, I think, and we will continue.
Thank you, Debbie. That 80% is a really good figure. Great. Well done, everybody.
Thank you, David. Any questions for David? Yeah. Okay, David, thank you. It looks as though the process are running well, which is, I think, the message we take from your report.
I think it is. We have a high level of assurance through the processes, through the QAC. That doesn't mean there aren't issues we discuss, but may cause us individual concern. But actually, I think as an assurance committee, I'm very happy.
Thank you very much. In which case, we can move on to the executive report. Julian, did you wish to say anything, or?
Yes, please. Yeah, I mean, I want to talk about the NHS-EI paper, but so if there's any other questions about anything else, should we? And then perhaps I can say a few words about that. Let's see if there's any questions about any other topics.
Yeah. Anything else for Julian before we get on to the paper? No, I think we're waiting for you, Julian, on integrated care.
Okay. Yeah. Well. So the paper came out, and actually, it's a relatively straightforward read. And in some ways, it seems, a helpful blueprint for the next steps in integrated care. And I suspect most people have sort of probably got at least a grasp of what this might look like. It is light on detail, though, and I suppose that there's the upside to it is, it looks like maybe some of the bureaucracy of the commissioner-provider split will disappear, and CCGs will disappear, and we'll have an integrated care system that does strategic commissioning, and provider collaboratives will do a lot of the pathway design and everything else. There is some gaps, though, and I guess the devil will be in the detail about how it gets implemented. So, for example, take the financial regime where there'll be a system pot. How do you drive out efficiency amongst providers if you've just got one big pot of money? Our experience last year was that we had a pot of money and we were all attributed the same efficiency in order to sort of address the sort of worst case scenario in the system. So how do you get the right levers and incentives around finances? On provider collaboratives, we've got some good examples. Alex has been overseeing for some time now the MSK pathway in West Berkshire, where we're working with the Royal Berks and the primary care, arthritis care on a kind of whole new redesign. Some good work going on with frailty in East Berkshire. So some good stuff there. But we could be involved in a dizzying array of provider collaboratives because we work at a regional level on specialist mental health commissioning. We could be working with primary care networks and doing this both in Frimley and in Bob, to the point where actually you may find yourselves in too many networks to be able to be effective, really. And again, you can imagine the region almost counting how many networks each provider is and everything else. So again, just the way in which how much latitude and freedom there is around the provider collaboratives will be interesting, and exactly how much authority provider collaboratives have in relation to the strategic commissioner. So what's going in strategic commissioning, some of it will be a grey area, and you could say, well, actually the providers could resolve those issues. So I think there's quite a bit for NHSE and I to kind of resolve around this. And my slight fear at the moment is that it becomes quite a prescribed system, and you could end up with just a different form of bureaucracy. So that's the bit that we'll have to try and resist and try and find a way through, that actually it's as lean as the kind of schematic suggests, rather than we building up quite a lot of bureaucracy. So it's a kind of logical, in paper, kind of progression without being too heavy-handed. It's just now the implementation that we'll have to be sort of be thoughtful about, I would suggest.
Thanks so much, Julian. I mean, I share your analysis exactly. I think there's some clarity about CCGs and ICS in one of the options about simplifying those layers. But I do get slightly concerned that the good words about subsidiarity, which are in the paper, etc., may be overtaken by excessive attempts to design the whole world as a new world before we get on and do anything. And so I can sort of see a 20-year journey, of getting new committees, new relationships, and meanwhile the patients aren't getting improved care. So I think we need to sort of make sure we balance the two. One is about understanding where the advantages are and how we can play to improve the system overall, and the other is working with our partners, again as a system, but working with our partners to deliver improved pathways where we can just get on with it, and not wait for someone to tell us what to do. So I encouraging Julian to just get on with working with Frimley, with Royal Berks, etc., to keep pushing forward specific things we can actually do whilst we're having this wider debate about how the overall system should look in the future. So that's my general feeling. It's good debate, by the way, with Bob, good discussions with Bob, and Frimley is now beginning to have good discussions. So hopefully something will clarify in the coming months. Chris.
Yeah, really, just to echo what the pair of you said, I mean, my reading of it was exactly pretty much the same as Julian's. I looked at it and I thought, well, actually, this is going to go one of two ways here. It is either going to become an excessive bureaucracy run from the centre, or it's going to be a hospital pass to say we've defined the problem, and now you define the solution without necessarily the parameters. So I think the governance, fixing the governance approach such that subsidiarity is capable of working, but within a system where, should we say, staff are encouraged or individual areas are encouraged to just get on with it and get some stuff done, is the key to what happens next. And I don't quite see, certainly I'm much more exposed to the Frimley side of it, but for me, that's I think the thing we've got to get working. I don't think there's anything in this paper that I would really disagree with, but quite what you do next is the bit that, you know, I'm slightly concerned about, but I think it is what it is.
Okay, any other comments, views? Alex?
Yeah, I do read some benefit into this if we can get the provider collaboratives to work, and that's about prioritising what we work on together, isn't it? There is the opportunity, I think, that will come from further delegation of budgets from CCGs to provider collaboration within the ICSs, and delegation of budgets from directly commissioned services, specialist commissioning, to ICSs. So getting the money closer to those that are delivering on the ground can only be a good thing. But as we've all said, it's about the priorities for the system and what we focus on.
Okay, Naomi.
Yeah, thank you. And, you know, echo others' commentary. I think directionally this feels absolutely correct. You know, and it has all the elements to it that I think some of us might have anticipated as we've moved through the last 2 to 3 year period. An observation of mine would be actually around the place-based partnerships, which I still find really, really tough to get my head around, principally because I think place-based partnerships are a critical success factor for ICSs. If place-based partnerships don't work, you know, I think everything else crumbles. But you know, the real at the heart of the difficulty of creating those, of course, is that the expectation is that they comprise multiple different bodies, including local authority and the voluntary sector. And I'm just mystified as to how, or what is the mechanism through you create place-based partnerships that are compelling, that work, the roles and responsibilities are clear, and you know they endure. And my experience of pulling together partnerships is a very different one. But what I do know is that if you don't have real you know, if you don't have a mechanism through which you define the roles and responsibilities, you're abundantly clear about who's doing what, when, who's accountable for what, when, how the work program and budget is going to operate, and it has a, you know, has a cadence, and it has a governance structure, etc., etc. And there's recourse if people fail, and there's a performance management system, and etc. It's just incredibly difficult for me personally to understand how that would work.
Thank you, Naomi. Julian's going to tell us the answer, I think, and then David.
I think David was before me, actually.
Oh, sorry, David. Okay.
Thank you. Well, I think I'm going to say the same as Naomi, but in using different words. Place-based partnerships to gain support from the members of that partnership. They will want to plough their own furrows, do their own thing, respond to patient care requirements as they feel fit. And it's a bit like the council situation, isn't it? When you have a number of relatively small areas, how do you coordinate those different clinical managerial approaches into one? So if it's, I think you can do that locally. It's a 99% of the work is local. But if you take heart disease, perhaps only 50% is local, because 50% becomes to do with the hospitals and the tertiary centres and the NHS and a wider event. So I think there will be dozens of areas of tension, and it's how you do what Naomi said, taking into account the localities wanting to improve care for their patients.
Julian.
Yeah, with a couple of sort of comments in mind, and we've got our strategy to think about. I guess one of the things that would be helpful for us to be thinking about in terms of integrated care and what's our role in integrated care is really giving some thought to where we think the priorities are for provider collaboration, rather than waiting for others to come to. So I think that would be quite an important sort of thinking in terms of we develop our A3 in terms of strategy. Where do we think there's influence and a good rationale, rather than just it's something we're good at. What would bring the system together that would make a difference for patients? So I think that would be helpful for us to give some thought, so we're a bit on the front foot and we can influence that, because clearly we're not the biggest provider, but actually we are the provider that transcends quite a lot more pathways than others, and quite a big geography too. So I think there's something around that. And then the place-based bit is really interesting. I think Martin and Naomi talk about some of the collaborations or partnerships in a way that's often more formal, I think, than what's expected here. See a whole array of stuff under that partnership sort of umbrella and collaboration umbrella that may range from formal lead provider kind of role with delegated stuff right through to something that's called a partnership that's much more loose than that. And as we'll come on to it in part two, I think Bob and Frimley at the moment have a different perception of place. So in Bob, place is the very big county councils of Oxfordshire and Buckinghamshire and the whole of Berkshire West, i.e. the 3 unitaries, because we've already got local authorities with a governance structure and everything else. So we're already doing stuff in Reading and Wokingham, and we can carry on doing that, thanks very much. What's the gap is just working at a bit bigger scale, really. And that's where the work in Berkshire West is. In Frimley, they've designated the 5 local authority areas, one of which is tiny, Surrey Heath, as a place. And now they'll carry on being local authorities with their own agenda, and we'll obviously work very closely with them, as we always have had. But the question is, what will be fundamentally different in those places as a result of this? Because they're already doing stuff at that local authority level. What will bind us together? And again, that's some thinking we can give when we're thinking about the difference between Bob, and we've got a paper in about Frimley in part 2 that we can have a look at and think about.
Thanks so much, Julian. Well, I think this is one of these issues that's going to take some time to resolve. And I did notice the paper had a little short paragraph on trust and about the importance of trust between partners, which I think is really important. And I'm pleased to say that my perception is that our relationship with our colleagues and other providers is good, open, straightforward. So there's a basis there to discuss some of these more difficult issues as we go forward. And talking about partnerships, which Julian mentioned, these softer partnerships, which is clearly something the NHS likes to do. The only danger I have with that is that people making everything look like a partnership because that's what they think is expected to do, rather than concentrate on what value we're actually delivering to our patients. And then the partnerships can be seen as being real, because whatever form they take, whether it's contractual or whether it's a softer partnership, we can be confident that they're actually delivering improvements to our patients. We don't want to just tick a box. We want to make it real for our communities. So I think we have plenty more time to talk about this. Thank you very much to Julian for the paper. Anything else for Julian on the report? No. Okay. Can we then move on to finance, item 8, Alex, month 7.
Thanks, Martin. So just to remind board members, we've been operating 2 financial regimes in this financial year. The first 6 months were a centralised block funding allocation to the trust, against which we could recover all and any costs, including COVID, to a break-even level. That was to support pandemic response. The second 6 months of the year are now based on a projection to the year end, so a 6-month projection, which the board will note from papers here. We have a memo column showing the 3.2 million deficit forecast over the next 6 months. That includes a 1.4 million annual leave provision. So excluding annual leave provision, 1.8 million deficit forecast. Beyond that, calculated by the centre, and you can see in our numbers, we are provided with 2.8 million of deficit support. So the first table on page 117, and just to clarify, apologies, it's not particularly clear from the heading of the table. We are just showing month 7 and month 7 year to date in this position, 2 million deficit forecast, and in month 7 we are showing a surplus of 200k against a planned deficit of 100k, so doing slightly better. Having a look at results across Bob, that's a similar position across, doing slightly better than forecast already in the month 7 position, and as system partners will be reviewing that as we look towards closing a small system gap of about 15 million in Bob towards the year end. We consolidate our 2 financial regimes in the table in page 120, and you can see there the first 6 months showing a break-even position at the month 7, and we're tracking along to that forecast position. And what I'll do as we move forward is just show that forecast and how we're tracking in a chart view, so it's easier to see. So nothing of concern at month 7. We've banked months 1 to 6 as break even, and on we go. In terms of cash, we are still benefiting from two block payments for April and May. That will unwind towards the year end. We're waiting for guidance on that. Our capital plan is in line with plan. We're progressing that, and our working capital position, I'm not highlighting any risks at this stage.
Alex, thank you very much. Any comments? Julian, is your hand up new or is it old?
Old one. Sorry, apologies.
No, don't worry. Didn't want to cut you off if you had something to raise. Any questions? We're going to have a chance to talk a bit more detail in part 2, I think. So, Alex, I think that's fine. Thank you very much.
Okay.
Performance report, Alex, 8.1.
Yep, take that as read. Highlighted the key exceptions on our driver metrics. Happy to take any questions as colleague execs will be as well.
There was something about self-harm. Self-harm is a bit of a problem at the moment, isn't it? Is that right? I'm trying to find the right bit on the paper now. And your driver metrics. Bluebell and Snowdrop. I don't know if anyone can just say anything to that, Debbie. Or
it's driven by a couple of individuals, Martin.
Oh, that's right.
Which
Sorry.
we'll be working through,
yeah,
and supporting them with safety plans, etc.
I remember now. It's the trouble of finding the right bit of paper on the computer. Any other comments or questions on performance? No, that's fine. Alex, thank you very much. We'll then move on. Board vision metrics.
Yeah, so this is our regular view of the metrics that support our vision. We have an action in train as an exec team to review our vision metrics in light of the 3-year strategy, which we're coming on to in papers. So this is the latest view where we have the data available. Unfortunately, latest benchmarking for 1920 wasn't in sufficient detail, will be in December, and I can update that at the next report. And I'm just highlighting fairly stable view of the vision metrics on the front page here.
Alex, I think we can be confident it will improve with the benchmark. So restraint, for example, we know has improved even further, hasn't it, in the recent benchmarking. So it will be an improving picture from the current data.
That's right.
And you're proposing, Alex, that we as a board, we look at this again sometime earlyish next year.
That's
just
right.
to refresh, to make sure we've got the right parameters on the top.
Yeah.
Thank you very much indeed. Any comments or questions? Okay. Thank you, Alex.
Naomi has one.
Oh, sorry, Naomi,
Martin,
please.
Very quickly, I just find myself unable to move beyond this paper without just pausing momentarily on the patient-on-patient assaults and the patient-on-staff assaults, and we do have a deteriorating position. You know, I'm not asking for a kind of full insight here, Alex. I just have a reflection that I think we've done quite a lot in this space, you know, over the last sort of 2 to 3 year period. And it does come as a little bit of a surprise to me that our position has deteriorated. So any high level commentary you want to offer at this moment?
Yeah, it's based on old benchmarking data vision metrics report. If you go back to the performance report, you can see we're below our target and a downward trend. So I would hope to see that starting to come through in the 1920 benchmarks. And we need to consider how we use benchmarks in the vision metrics going forward, because they are so out of date.
Oh, understood. Thank
you.
That's right, Naomi. So the benchmarking data you're looking at is from 2 years ago.
Yeah.
The one that we'll see next month will be the previous 12 months when you'll see an improvement.
That's something of a relief. Thank you.
Yeah.
I think it's where we need to make sure we don't look at the vision metrics too often, in the sense that we get confused with the monthly performance data, but we use it to stand back over a sort of a year and say, you know, how did we actually do against these big chunky parameters? Any other questions, comments? Okay. Sorry, for some reason the papers are just flipping over the wrong part of the screen for me. Right, COVID-19 recovery plan. Catherine, you're on stage.
Thank you. I'm going to take the paper as read. Hopefully it's very straightforward. Just a couple of things to highlight. We've started, there's a requirement under the phase 3 guidance to have what's called a reducing health inequalities from COVID action plan. We've started that piece of work. So that's started. The only other thing to highlight, we do have in place a prioritisation framework, basically services that if we did have to start pausing, we do have that framework in place, which fortunately we haven't had to go to yet. So they're probably just the 2 bits to highlight from the report, but happy to take any questions or comments.
Any questions or comments for Catherine? Chris?
Hopefully just a very straightforward one. The only thing that slightly concerned me was, you know, when I looked at planned completion date September 2021, I just wondered whether you were trying to, should we say, dilute expectations, or whether that's a sort of I suppose a national thing. You know, I just looked at it and I thought, presumably a lot of these things are far quicker than that, and September 21 is an absolute end state, provided something new doesn't come along to bowl us around our legs in the winter of 2021.
Yeah. No, I've done exactly as you suggested, Chris. I've just tried to put a long stop in, and hopefully everything will happen an awful lot quicker than that. But there's just so many unknowns still. So yes, I've done exactly as you suggested.
Yeah.
Anything else? So there's nothing untoward you want to bring to our attention, Catherine?
No, in terms of recovery, we have a system and process in place that's managing that. It really at the moment is about the impact of wave 2, and we're managing that. So it's as stable as it can be in this bizarre sort of scenario that we're in. The expectation is that incrementally we will continue on the recovery journey. We just need to see what else happens in terms of any further waves, the success of the vaccinations. There's still quite a few unknowns in the mix.
Debbie, are you able to give a general view about the current position in COVID in the Trust?
Yeah, sure, Martin. So from an external perspective, our most challenged area in terms of still seeing increasing COVID cases and activity is Slough, which is in tier 3, and the other 5 local authority areas are in 2-tier and are starting to see in the main a slight reduction in cases. From an internal perspective, there's been much less COVID activity since the last board. We've got at Prospect Park now only 3 cases, and the 2 outbreaks we had on the older adult wards are now closed. When we talk about outbreaks, we mean 2 or more cases that might be linked, and they're closed 28 days after the last case. That's the Public Health England national requirement. So much less activity at Prospect Park, and we have cohort wards for any older adults and also for any adults of working age that are in there. So much improved position at Prospect Park. And in our community health wards, we've had a few outbreaks. We've now got 2 what PHE would call active outbreaks, and that is at Oakwood and on Ascot ward, but we're actually talking only 1 or 2 patients. I think we've got a total of around about 10 patients across all of our community health wards now that are COVID positive. The vast majority of them, all by 2, are either transferred to us as known cases for their continued journey once they're stable enough, or they are admission positive. We've got two of those patients that are post 8 days. So a much improved in terms of COVID activity on our inpatient wards at the moment. And from a staff perspective, many of our staff that were off towards the beginning and mid of November are returning. So that's positive as well.
Excellent. Thank you very much. Any questions for Catherine? Comments?
No.
No, thank you very much indeed, Catherine. We can move on to. Oh, sorry.
Sorry, Martin.
Oh, yeah.
Just wondered if and where we're going to have the update on the COVID vaccine arrangements, or an update just on what's happening in relation to that.
Debbie, are you able to say anything?
I'm able to say that we have. So we know that we've got 2 hospital hubs that are active and up and running, providing vaccinations as of this morning. And there are some of our staff, our highest risk staff and our staff that work into care homes, able to access that. And I can provide a more detailed update in part 2.
Thank you.
Thank you very much. And just before you move on to strategy, Catherine, just to say, I've been having virtual visits to frontline staff, as you do, to replace the physical visits we used to make. And just recently, I've been talking to the psychological medicine services at Wexham and at Royal Berks. And I was impressed actually by their commitment and their positive approach to the pressures they're under. But the point they did raise is that seeing much higher acuity, more seriously ill patients, mental health patients, than they would traditionally have done. So, the stuff coming through, and they said they're not patients who they're familiar with, coming in, but they're actually patients that they wouldn't normally expect to see. So it's obviously quite a bit of pressure, particularly in those areas. So I thought I'd just feedback, partly as a bit of information and partly just to say how impressed I was with the teams there and what they're doing. So, Chris.
Yeah, and just on that score, David and I had a virtual visit to the heart function team in East Berkshire back in the last week, and I think we would echo that. There was certainly a very positive, highly motivated bunch who were really, getting down to it and, and doing a great job. The one thing that I think came from that session was that their ability to perhaps they are seeing an unprecedented increase in activity, and put that down to the, if you like, some of that down to, I won't say long COVID, but to the impact that COVID can have longer term on hearts and lungs and things like that. And they were highlighting an area that I would encourage us to take up with commissioners, which was a view that there was a service operating in the west. There is a commission service in the west of the county that enables significantly higher levels of, if you like, productivity of staff because of the digital footprint and digital service that's available. And this is not a service that's offered by or funded by East commissioners. And it would appear to me that unless we think there are rabbits that we can pull from a hat in terms of staffing to meet an increased level of activity, which I think are going to lead to significant waits in that service if we don't step up to the plate, that we should be encouraging commissioners to think about how they might help by funding and extending that service to the east of the county. David was able to, should we say, point to some of his experience in other areas, even overseas, where the services that are in place in the west of the county are capable of doubling and trebling the level of productivity through the use of digital formats. And it seemed to me to be something where we should be applying pressure to the commissioner to catch up with the 21st century.
Very good. David Buckle, did you want to add anything to that? Or? Yeah.
No, Chris has summarised it. I'm not sure it's doubling or trebling, but we do know that if you use IT sensibly, and it does involve a significant investment. These are very, very high risk patients, and I was saying when I was a medical student, their life expectancy was worse than cancer, and it's tremendously increased. Heart failure is such a treatable condition compared with what it used to be, and it is simply measuring blood pressure, measuring weight, doing blood tests, and that is obviously something that can be done digitally these days.
Very good. Well, thanks for that. Thank you, Catherine, Debbie, for that. Can we move on then to the longer term, Catherine, the strategy paper? I think you can assume we sort of read it, but I think it'd be useful if you can just pick out the key sort of strategic issues that you want us to get out from the paper and want to get across.
Yeah, very happy to do. You've had an opportunity a good few times now to input into it. I think the one thing I would like us to look at again on page 176 of the pack is the 2024 vision. So we had a good old stab at this in the last meeting. I wanted to make sure that we feel it's visionary enough. We've got a lot in terms of patient experience around extending the service offer to them. We talk about the initial contacts being triaged remotely where appropriate. We talk about continual engagement with patients and co-design with patients. Excuse me. So that section feels quite strong. The workplace wellbeing section, we've had the benefit of the people strategy, so I've been able to cross-reference to that. And I think that's probably a really helpful link across. And you'll see that I've taken the rainbow from the people strategy included in our vision here. The bit that I think we might want to consider, and it was really helpful to have that feedback on the heart failure and it's heart function service now, is the supported by technology and whether I have encapsulated enough ambition in that section. So there is something about how can we word what we wanted our ambition for digitally enhanced services going forward. And a challenge I had yesterday in the exec team conversation about this was including reference to supporting staff continuing to work from home. So it's that new way of working. In terms of caring for the environment, having come back and had another look with fresh eyes, I can see that there's a little bit of duplication in there. But I think I'd quite like to stop and see if there are any comments or suggestions or further thoughts on the actual ambition I set out. And I guess my challenge back, is it ambitious enough? Have I been able to capture enough? And looking at that digital corner in particular.
Okay, I think probably can we stick on that slide then, that diagram, and invite comments. I mean, there is a little bit of duplication if you read it through, but it's just minor editing stuff to get that out. I think having looked at that and read it as a sort of lay person, if I was seeing it fresh, I'd be able to pick out, the general direction of travel of where we're trying to get to. And I think there's always a danger in these things. You can add too much in. You want to get every little bit that you want to remember on the chart, and then you lose the overall direction. I'm just wondering myself about the population, the inequality in population issues, which is a major part of the strategy. I think it's there in the patient experience. I can't see it on this computer screen at the moment. But it just felt whether that needs to be made a little bit more prominent, because some of the other things like the environment and some of the workforce things, the duplication there is about working from home rather than having to travel everywhere, which has a benefit for the environment, but also a benefit for staff not having to drive and flexibility, working, etc. I just wondered if there's something there, but it's just a general observation. But the general track, I can pick up very clearly from looking at that diagram the general direction of travel we're trying to get to. Now, I don't know who went first. Alex, I think.
Yeah, Catherine, I think on the vision graphic, a lot of the ambition in technology is stated in there, but it's within the patient experience corner. So an extensive range of advice and info available online, tools and support to enable self-care, empowering patients and communities, the current state of our excellent online consultation, etc. So I don't know whether it's about pulling that out and embellishing that a bit more if we want to get more of an emphasis on the digital aspects. And then I would just be really keen to say our people, not our workforce, because there's a 3 Ps thing, but more importantly, our people is our people strategy, and it's a commonly understood term that our people means our staff and workforce. If that is okay with board members, please.
I can't believe anyone's going to object, Alex. Workforce does bring up a vision of Victorian workhouses, and okay, Chris, and then Julian.
I think Julian was certainly before me.
Oh, sorry, Julian. Forgive me.
Thanks. I sort of read it again and tried to sort of on the weekend think, okay, I'm doing a well-led inspection and someone else is passed me this document. Where does it help me sort of get somewhere? Because sometimes you get a bit too close to things, don't you? And there's a couple of things really as a result of that. I don't think the digital stuff is as clear as it could be. I don't think the next step. So our digital, we've already said, is going to be the major transformational kind of thing that we do. We're already very good at it, and most of the things that are referenced we're already doing in 2020. So in 2024, what will be kind of different? In my mind, I was thinking, it's going to be those things that will really make a difference at scale. So we do monitoring of patients and inpatients at the moment, but that's a few hundred people. In the future, what the world of tomorrow needs is the stuff that Chris and David have been talking about, which is remote monitoring at scale in people's homes and using digital in that way, really. In 2024, you're able to look after your whole district nursing caseload, your community matrons, through digital information coming back, so they only visited those who needed it. That would be transformational. Again, the point of care testing, we're small scale at the moment, but inevitably you think it's in there. So we need, at least if it's not those areas, to signal where we think the next step is in terms of digital. Otherwise, there's a danger that the sort of narrative really sees us pretty high performing now, but if we don't move forward on that digital, 2024, everybody else will be doing that stuff already, I think. And then there was just a bit on the other slides, which was just a bit dated in terms of language. So it talks about in the last 6 months of the COVID. So if I was reading this document in 12 months' time, it just feel like actually it was out, as opposed to the more general point about our vision is that around a third of our workforce will predominantly work at home. I think is just what we need to say. So there's quite a few of the things that just look like it's a COVID strategy rather than a longer term bit. And then Martin, my final point is on Martin's prompted a thought on the health inequalities, and I wonder whether we could tie up the addressing health inequalities in the vision, working as a provider collaborative, because again we've got to be contemporary with the national thinking about, what would we work on as a provider collaborative? Well, we shouldn't just be working on the pet projects. It's probably driving inequalities and working together on those areas, targeting the BAME population, for example, in Slough as a provider collaborative in order to make a difference.
Yeah, just before I invite Chris, Julian, Oh, Catherine's gone. Are you there, Catherine? Sorry. Just following up on Julian's point, if you go back to page whatever it is, can't see the page of 3 strategic objectives page where you've got our patients, our populations, our workforce, they're now to be our people. Your diagram, your graphic that we were just talking about, it might be useful if somehow it can have the same basic structure as that. So there'll be things which show how you're going to solve some of these things in the longer term, but it just sort of keeps it a simple sort of taxonomy, if I can put it that way. But just as how to keep it simple. Otherwise, you go through the document and you start seeing 3 headings here and then another 3 or 4 headings in the graphic. It just it doesn't make it as straightforward as it might be. So just a thought. Chris.
Yes, and the danger of stepping aside and to let someone as articulate as Julian speak in front of you is that he's always very likely to say pretty much exactly what you were going to say and in a better way than you were going to say it. So edit, copy, edit, paste all the stuff on digital that Julian said. I think for me, coming out of the sort of heart function thing we talked about, and this sort of nirvana of getting to a place where we, perhaps by 2024, where as much of the routine observation stuff is done digitally, allow our staff to be, should we say, operating at the top of their game, at the sort of harder end of their caseload. I think coming out of that experience with heart function, I think what we need to do within digital is to ensure that we have a conduit to allow the people at the front end to be feeding in the digital capability requirement that they are going to have, because only by chance are us people sitting around in a place like this, or even and even less likely commissioners to commission services. I think the eyes of this organisation on what is possible and what are our frontline staff. They know what they see their peers. They have experience of what they've seen others. And I think for us to not somehow, we need to maximise the engagement of staff, during the design, but even before that, during the identification phase for digital. And the only other thing I was going to say, really, on I'm like others, have sort of read this a number of times now, and I'm really comfortable with how it looks in the main. Is it, Catherine? Is any of this going to scare the horses in any of our other stakeholder partners? Have you been able to socialise any of this? Is any of this going to get any significant pushback from any of them, or are others going to look at it and say, yeah, that's where we want Berkshire Healthcare Trust to be?
I think there's probably 2 areas that would I probably want to highlight. The first would be internally. You'll see in the which section is the sustainability section, we reference a smaller number of sites. So if a member of staff was to look at that, they might ask a question about what does that potentially mean for me. I think the other area that is not so much scaring the horses, and it is the direction of travel, and we had included it in the earlier drafts of our strategy, is the reference we make to integrated physical and mental health services with primary care networks. And we had signalled that before we went into COVID, but it feels a very different place now because primary care is under such a lot of pressure. So I don't think it would scare the horses, but I think we probably need to think about how we do that now. And now we know about the provider collaborative ask as well. So as a high level, I don't think it's scary, but I think what we need to do to deliver that and how we probably need to have another think about and do the engagement piece again that we had done previously.
Okay, Catherine, I have some helpful comments there.
I have indeed.
Unhelpful.
No, very helpful as always.
My experience of doing these strategies in other worlds is that you really want to keep the themes that you have few, clear, and really meaningful. That is, they really are going to things you want to change the world. because one of the dangers is you can write these things, you know, whatever, it sounds nice and in line with current thinking and all that sort of stuff, but it doesn't really have the bite, so that when you come to make decisions downstream as an organisation, quite often they get watered down. There's something else comes along, gets in the way, and if you give too much complexity in the strategy document, there's a danger that just encourages that sort of thinking where everything gets broken down to small bits and you lose the thrust and general direction. So I would just encourage always to keep it simpler and but real, you know, concrete. And just you mentioned, I think someone on the integration side. I mean, whatever these things are, if this is the way we think it's going to go, for good reason, that is, we really want to do it, then we just have to cope with the consequences accordingly. You can't shy away from doing the right thing just because it may be difficult. We don't want to cause difficulty, and we need to manage any consequential sort of collateral damage carefully. But if that's where it has to go, as senior leaders of an organisation, we have to face up to that. But great. So now you're going to go away with your executive colleagues and tweak it. Does the board wish to see it again, or are we happy to let the executive do it?
Let the exec do it.
Okay. So Julian, we'll leave it to you and your colleagues to tweak it and get it out. And what's the plan in terms of issuing this? When?
Well, I hadn't planned to do a big launch at this point in time because of everything else that's happening, but we would look to have it put on our website, and we would be looking to have it printed in the format that you've got in your appendices, so you've got an idea of what it would look like. Probably what we make sense to do is in the new year, we have a people strategy, an EDI strategy and a 3-year strategy. It probably makes sense to do something across the whole staff piece where we socialise all of those strategies together. But that will be at a point in time when we can do something more, you know, face to face with people. In terms of socialising with our partners, that's fairly straightforward to do at this point in time, and we would be able to do that even though we're in a sort of remote working space at this point in time still.
Okay. I just a slightly cynical plea from me is when I get a bit of paper in the post that tells me that I should be going online, you know, you wonder why they sent the bit of paper in the post when I'm already online.
Yeah.
And printing these things is sort of satisfying to see the bit of paper, you know, the strategy document. I just think reflect on whether we want to print 4,500 of them, as physical things rather than find another way of communicating it. But that's just me, my irritable mood. But anyway, thank you very much. Good. And we'll move on to Appointments and Remuneration Committee. Mark, terms of reference.
Thanks, Martin. Yes, at this morning's Appointments and Remuneration Committee, we ratified these 2 minor changes. The first to the terms of reference is to allow us to procure remuneration benchmarking, which may well be required to supplement the fairly out-of-date information coming through from NHSI. And the second is to allow us to apply an alternative payment policy for the pension arrangements. Those are the only 2 amendments made in that, which all of the Remuneration Committee approved this morning.
Thank you very much. I think we are happy with that. Councillor Governor's update. I've raised some of this before, but just to say the coffee mornings that I have seem to be going well, and lots of governors taking part. A useful way of just helping them understand some of the issues in between meetings. The governors are quite seized, I think, now with the issue of diversity on the Board of Governors to see how we can improve the diversity to reflect that of Berkshire. And we have several elections coming up for governors, which are duly managing well as always. So if you know anyone who wants to stand, always good to have a good competition. So thank you for that. I've got nothing else. Any other business?
Could I just ask a question?
Please.
Martin, in respect to the Council of Governors and their role as the ICS, thinking around the ICSs matures and the direction of travel crystallises. And this is probably a really naive question, but the role of the Council of Governors and that they might play in that seems to me they have a role, but I don't I haven't sort of formulated in my own mind how changed it might be from current. Any thoughts?
Well, I'm just amazed you didn't know the answer, Naomi. I mean, there's two aspects. One is that I think there's going to be quite a long time before we really understand the governance arrangements for the ICSs and the formal roles governors play. Although, of course, as a trust, foundation trust, their role is related to us and the decisions this board makes. There is another issue which is related, which is about helping the governors to understand and be informed about the developments. Now, there's a balance to be struck because there's so much moving at the moment, so many different papers, so many different opinions. It's quite tricky to give them a sort of a succinct and meaningful briefing. But I've been in discussion with the chair of Frimley, Pradeep, and I think we're both coming to the view that we need to do something to help our governors understand as the world slowly begins to clear. Because if we do get to a position where there might be some significant decisions for the trust, we don't want the governors to feel bounced. We don't want to suddenly say, well, why didn't you brief us about this before? So it's about this business of not overwhelming them, but as we move to some clarity, then they're properly briefed, and to do so in partnership with our other key providers in the system. So I think that's a sort of evolving picture, but it's a good one to raise. But as to what the final answer is, I do not know.
Thanks, Martin.
Julian may know, but I don't know. Julian's smiling, so he probably does know. He's just not going to tell me. David.
Well, I suppose all I would reflect is, of course, it's only foundation trusts who have governors. So, their role will change if providers move closer together.
Okay, sorry I rushed you, Naomi, on that. Any other questions or points? Any other business? Okay, next public board meeting is the 9th of February 2021. And we'll now consider our usual resolution to exclude press and public for the remainder of the meeting, as publicity would be prejudicial to the public interest. So we'll take a break. Shall we have 15 minutes? Is that all right, or too much?